Information gained from viewing the following program is not a substitute for regular exams by your physician and does not constitute a doctor-patient relationship. All information gained should be discussed and confirmed by your physician.
Hello, welcome to Healthy, Wealthy, and Wise. I'm your host, Ed Krick, and this is my wife and co-host, Beverly. We're so glad that you've joined us today. We trust that you'll be able to find from our program some things that will help keep you healthy, wealthy, and wise. We know that health is our greatest wealth, so we want to be sure that it's a top priority in our living and that we use the principles of prevention so that we can keep in good health. Could I suggest that you might want to get a pencil, a piece of paper? There may be some things that you'd like to jot down about our program today that will help in keeping healthy, wealthy, and wise. We're so glad to have as our guest Dr. Stephen Hodgkin, a board-certified dermatologist, graduate of Loma Linda University, who practices here in Redlands and in Victorville. We're going to discuss some of the problems of skin rashes, skin problems, primarily concentrating on rashes. And one of the worst things that we think about is skin cancer. So why don't you lead off a little bit and tell us some of the things that we need to look out for relative to skin cancer. Can it look like a rash?
Sure, actually skin cancers can look like a rash. But just to kind of give a quick overview, skin cancer is very common and becoming much more common in the last, several decades. Basically, when it comes to skin cancer, probably there'll be over 1 million cases diagnosed of skin cancer.
Oh my.
Primarily, the good news is most skin cancers are not, life-threatening and fatal. So we'll start off with the most common type of skin cancer is basal cell carcinoma. In fact, it's the most common cancer in the whole country every year that's diagnosed. Probably about 800,000 cases of basal cell carcinoma this year, and it'll go up next year, probably a higher number. But basically, basal cell carcinoma it looks usually like a shiny bump on the skin that might bleed easily or have a scab on it. You can look a little translucent and maybe see some little red blood cells inside of it.
Mostly
and
face?
Sun-exposed areas. So face, hands, legs, but all over, actually, because, sun hits almost the entire body once in a while at the beach and the pool and stuff. But so basal cell carcinoma is the #1 most common skin cancer. The next most common skin cancer is squamous cell carcinoma. And squamous cell carcinoma usually just looks like a red bump growing on the skin. It can be scaly or crusty sometimes. And usually squamous cell carcinoma, like basal cell carcinoma, is not life-threatening, but unfortunately some people neglect their squamous cell carcinoma cancers, and they get larger and do metastasize, especially if it's on the lip or the ear. It has a maybe up to 15 or 20% chance of metastasizing, which is quite high, especially for skin cancer if it's neglected.
So if you see something on the lip or the ear, that's a sign you better get to the dermatologist right away, get it checked out.
Yeah, you should check all spots, but the lip or the ear probably, go faster, I guess, to be checked out. And just to follow that up, whereas almost, probably less than 100 people die every year in this country from basal cell carcinoma, and I've only seen a handful in the last 15 years or so. But squamous cell carcinoma, about 2,500 people die every year of squamous cell carcinoma of the skin. So that's serious, but it's usually people who are quite neglectful. And if they just get it treated at an early stage, it's much more curable. Now, malignant melanoma is the type of skin cancer that is more hazardous. And although there's more than 1 million skin cancers probably going to be diagnosed this year, probably maybe around 100,000 will be malignant melanoma. And malignant melanoma is basically a cancer of the pigment or melanocyte skin cell. So if you go out and you get a suntan, it's the melanocyte that, turns your skin that tan color. Or if you have a regular, good, benign mole, it's just a little benign tumor of melanocytes that is not hazardous. But when the melanocyte degenerates into a cancer and begins to replicate out of control, then you have a malignant melanoma. And the malignant melanoma, to recognize that, most probably, at least 95% of malignant melanomas are brown or dark color anyway, brown or black, maybe some gray color mixed in there. And whereas a good mole is usually small, maybe less than 6 millimeters, the size of an eraser, a good, just benign mole will be small, one color, and round without any abnormalities. So
no little projections
no little
on
projections. So just a quick, to recognize melanoma, they say the A, B, C, D, E rule now. It's A is for asymmetry, meaning one half doesn't look like the other half. B is for border, where the color just kind of bleeds out into the skin where it's not supposed to be. That's a sign of possibly melanoma. And so C is for color. You want one color. If you have more than one color, that's not good, especially gray in particular. That's always a very suspicious color. D is for diameter, maybe less than 6 millimeters. And then
the size of a pencil eraser is 6 millimeters?
Right, and then E, which they added a few years ago. They used to call it elevated, meaning raised, but a better use of the E is probably evolving, meaning any change. If you have a mole that's bigger, smaller, lighter, darker, itching, hurting, bleeding, anything, E is for evolving. Any change makes a mole suspicious. And if you have one or especially two of the A, B, C, D, E criteria, that mole should probably be biopsied and check it out to make sure that it's not a melanoma.
Oh, well, thanks for that warning. That is so important. We don't want any of those things to slip by us. And my dad died of a melanoma, and I've had one, so I'm pretty much tuned into that.
Familiar.
But I don't think I could recognize one really, even with all of that. So
Sure.
It's a good idea to see the dermatologist.
Yeah, and saying that it's hard to recognize sometime. Probably 5% of all melanomas don't have any color to them. So even though it's a melanoma of the pigment cell, the melanocyte pigment cell that gives you the brown color, probably about 5% of melanomas have no color, and they're called amelanotic melanomas. And so any little pink bump on your skin, there's a small chance it could be a melanoma. So even little pink growing spots on the skin, even smaller than an eraser, it is suspicious and could potentially, be a melanoma.
Especially if they're changing.
Right. So it's something that should be taken seriously. Can be life-saving to get rid of those early on.
Let me ask you, are there some ethnic groups that are more susceptible to melanoma than others?
Sure. If you have fair skin, especially Irish or Northern European of any type, that puts you at a higher risk. Probably mostly due to the fact that you get more damage from just the regular ultraviolet light exposure. If you have at least a little bit of tan or brown in your skin, it's essentially like wearing a sunscreen 24 hours a day. And even just a little bit of tan or brown color in the skin is probably equal to about an SPF 15.
Really?
So that's good. But now clearly there are some families that have a much higher risk of developing melanoma. And there are some families where it seems like every generation, several people in the family have had melanoma. And that's a genetically based,
Right.
melanoma. And probably
Right.
those people, even if they wear sunscreen and they really try to avoid the sun, each member in the family is at such a high risk of developing melanoma, it probably approaches 75 to 80% risk over a lifetime that you'll get a melanoma. So for families that, it seems like almost everybody has a melanoma, they should be checked very routinely for any possible changes in their moles.
So oftener than once a year then, sounds like.
Yes, and also if you really have an extremely high risk of melanoma, you can do photography, you can kind of do almost full body photography because, a lot of these people may have, 100 moles or more, which is, quite common actually. And so it's very difficult for the patient or for the, for the physician to keep track of every single mole and what every single mole looked like, because you can have a mole that's sitting there for 10 or 20 years behaving itself, and then it degenerates into a melanoma. But then also, and probably, most melanomas actually just come up just from normal skin, and it just develops new as a new spot. And so, yeah, that's a good way to find them early. Is if you have, photography of, your entire body surface.
Especially when
If
it's a
you
genetic.
even if you see a small little new mole that wasn't there, that's something that probably should be biopsied, especially over the age of about 25, because most people will not develop new moles after the age of 25.
Well,
so anything new that looks like a mole, even if it's tiny, probably isn't good.
Well, that's good.
It's something that should go.
Good information to have.
So,
After age 25, you want to see something
yeah.
new, you better take a look at it.
Absolutely. Very important.
Well, let's talk a little bit about rashes, and there must be a multitude of different kind of rashes, but what about infections with a rash?
Sure, there's many different rashes. There's kind of a smaller group of quite common rashes, and
Okay.
infections is one of them. And then there's many rare different types of rashes. But when it comes to infections, your skin most of the time keeps you protected from bacterial infections and viral infections and fungal infections and other yeast type of infections that you can pick up. So the skin does a good job just protecting and keeping out all those potential offenders. But if you get a little cut or scratch, or if you have like a diabetic ulcer in your skin, some breakdown in the barrier, certainly you can, run across a bacteria that will invade. And then when you actually have an infection that's clinically a problem, usually it'll get kind of hot, you'll get some fever, it'll get red and swollen, and it may get some pus coming out of there. And you can have large areas of infection, it's called cellulitis, that if it's not treated, it can actually spread to your bloodstream, and you can get septic, and that has life-threatening consequences. So then, bacterial infections, usually they're controlled with topical antibiotics or antibiotic pills.
Okay.
That'll keep that under control. And then the other infections, viral infections, there's, wart virus is an example. Once again, usually your immune system and your skin barrier will, keep those under control. But, when it comes to warts in particular, there's about 100 different wart types. They're just numbered. And every time you grab a shopping cart at Stater Brothers, or you open up a door handle or shake hands with somebody, you're being introduced to new wart viruses. And as long as you don't have a little cut or break in your skin, and you wash your hands a few times during the day, and your immune system is good, you won't really even develop any problem at all.
Right.
But sometimes it'll get into the skin, and you'll develop a wart or such things. Now the fungal infections, of course, there's fungus everywhere. Somebody did a research study, and apparently since the 60s, with the advent of people flying all over the world, like as an example of fungus being everywhere, people have done research studies, and they check hotel carpet, hotel carpet
Right.
in the rooms, and it's enough to give you the willies, but virtually 100% of hotel room carpet has plenty of fungus and fungal spores in it. So just walking around barefoot in any hotel will expose you to plenty of fungus.
So what do you recommend? Wearing slippers? Or?
Yes, absolutely.
And wearing gloves when you touch anything, it sounds like.
Well, you could become Howard Hughes, so you can't be too paranoid.
Well, you can't get too obsessive compulsive, but it's important to think about the cleanliness and washing your hands periodically, especially before eating and after going to the bathroom and so forth.
It's true. As long as you have a good immune system and you don't have cracks and splits in your fingers, as long as you wash your hands, a few times during the day, maybe definitely if you, shake hands with somebody that has the flu or some sort of infection, wash your hands to protect. Probably before you eat and after using the restroom is a good idea.
Oh.
But it's also important to remember that if you excessively wash your hands with a lot of hot water and soap, it'll take the oils out of your skin, it'll get dry and crack, and then you've got a real breakdown in the barrier. So everything in moderation.
Well, the same thing's
Good
true, I
idea.
guess, of showering, isn't it? If people use really hot showers, I know some of my patients have said they've taken a hot shower twice a day, and wash with soap and get rid of all the skin oils. That's not so good either.
That's absolutely true. That's one of my most common situations that I run into, is people are dry and itchy from head to toe. And then I'll say, now always remember, don't take a real hot shower. And they say, but I love taking a hot shower. And I say, well, don't use too much soap either. And they say, well, I don't use soap. I use a body wash. Well,
That's soap
basically the soap company's answer to sell lots and lots of soap. And when you watch the soap commercials, there's bubbles coming out of the shower. There's people just soaping up head to toe. So that's a big problem, especially in the winter. And the older you get too, your skin gets drier. So I see that all the time through the winter. And people, I have a hard time convincing them that the main problem they have is their hot, soapy showers, and it's a hard habit to break, but it's an important thing to remember. You just take out all the oils and all the barrier function of the skin, and you get dry and rashy, and then possible infections, and a lot of times that's what happens.
Oh my.
They come in with a big bacterial infection from head to toe.
Well, what's the recommendation then for how often should you shower and how often should you wash? And I mean, you don't want to be too smelly.
Well, that's true. So once a month, whether you need it or not, right? So, but in reality, probably one shower a day is adequate for most people. And you really don't need, on a daily basis, you really don't need to soap up your arms and your trunk and your legs, because the type of sweating that you do on your trunk and extremities, it's a different type of sweat gland. Just plain water will get rid of that sweat. Face, underarms, groin, probably some soap's a good idea.
Oh.
But you don't need to soap up your arms and trunk and legs, because that kind of sweat will just wash off. So I have a hard time convincing people of that. But it's definitely true. And people that definitely want to wash with their body wash, I tell them maybe once or twice a week, head to toe with the soapy scrubbing. But they also need to put on a moisturizer too, they just get too dried out.
Sure. Well, that's an interesting thing. I hadn't really thought of that before. If you wash with soap then kind of selectively, face, underarms, groin, where the different kind of sweat glands, then you take care of most of the need.
Absolutely. The sweat glands are different, and the plain old eccrine glands, which is just kind of a clear type of sweat, trunk and extremities, plain water is fine. The more sebaceous areas with more oil, that needs soap.
Interesting. Let's talk a little bit about what I can remember from my childhood. I was getting this athlete's foot all the time. What's the incidence of that, and what's been happening over the years with that? Is it still a big problem?
Well, it's very common, and as I mentioned, especially since the 60s, there's just fungus everywhere since the 1960s. And so essentially it's a good idea, even indoors, unless you're in your own home, and then it's easy to have your own home be colonized with fungus too. But the incidence, when you talk about the incidence of fungus or athlete's foot, and essentially what you see with that is just scaly skin, just kind of dry, scaly skin that peels easily. But the incidence basically is low in kids, and when you get to be 100 years old, it's almost 100%. And so it's kind of a ratio over time. And it's almost, probably definitely under-recognized, the incidence of fungal infections like athlete's foot. And probably by the age of 50 years old, probably 50% of the population has fungus on their feet, and they just recognize it as dry skin. And so when they come into the office, they'll say, I have these dry feet, and I put on, Vaseline and moisturizers, and nothing works, And so then, of course, when you tell them you think it might be fungus, they say, I couldn't have fungus. But it's just kind of a mild fungal infection. And so when you're 50 years old, probably about 50%. When you're 70 years old, probably about 70%. And when you're 100, almost 100% of everybody will get fungal infections, at least a mild fungal infection.
So how do you treat that?
Well, if it's just in the skin, usually a cream will be adequate. And there's many different choices. So like over the counter, even you can get Lamisil cream over the counter, which is pretty good. It's pretty good stuff. And then there's other prescriptions but for skin infections where you just have some mild peeling, usually just an antifungal cream is adequate. But one thing that's important to remember is you probably need to use it for 2, 3, maybe 4 weeks after your skin looks good.
Keep on using it.
Keep on using it, because the skin takes a good 6 or 8 weeks to kind of resurface, and on the feet actually, for the skin to grow from the bottom to the top to kind of resurface, it could easily take 3 months. So let's say you have athlete's foot, you treat it for a month, it starts looking good. You probably want to treat it at least another month beyond where you look clear.
Does sweaty feet, sweaty socks have anything to do with it? And should
Sure.
you change socks and be sure you keep dry as you can?
Sure, absolutely. Fungus tends to like, moist areas to grow. And so, changing your socks routinely, washing them well. Now, if you have, like you say, you have your favorite pair of tennis shoes that you've been wearing, there's almost no way to clear the fungus out. And so, sometimes I'll see people, they'll be looking pretty good, and then a few months later it comes right back. And you ask them, you say, well, what do you wear for shoes and everything? They say, oh, well, I've had the same pair of tennis shoes for 10 years. And unless you radiate the tennis shoes, I don't even know that'd kill probably would kill all the spores, but you have to switch to, new tennis shoes or whatever kind of shoes to make sure you don't reinfect the cleared up athlete's foot. And in fact, they say, fungal spores in a pair of tennis shoes, if you just sit them in the corner, it can probably last 10 or 20 years.
Oh my, that's kind of
So
Kinda
it's a
scary.
thought.
a little bit scary, isn't it?
Exactly.
Well, tell us a little bit about psoriasis. I know it's a fairly common problem. How do you recognize that?
Yeah, psoriasis is very common. Probably about 1 or 2% of the population actually has psoriasis. It's a genetic disorder, and psoriasis tends to run in families. In fact, if you actually check for the genes, there's a few different genes that can predispose you to psoriasis. Probably 50 or 60% of the population actually has the psoriasis genes. But probably, it's about 1 or 2% of the population actually exhibit the psoriasis rash. And psoriasis, basically, what it looks like is red, scaly areas, kind of plaques, red, scaly plaques on the skin. And the reason it looks that way is psoriasis basically is a condition where the skin grows too fast. Like regular skin on most of your body takes, maybe 4, 6, 8 weeks to grow from the bottom to the top. I did mention the palms and your feet, the soles of your feet, maybe 3, 4 months to actually grow all the way out. But most of your skin takes a month or 2. Now with psoriasis, the skin is growing too fast. And it may actually grow, the epidermal layer, it may grow from the bottom layer of the epidermis to the top in a week or 2.
Oh my.
And so that's what the problem is. It gets red, it gets bumpy and scaly.
But that's fairly easy to
So-
diagnose and treat, is it?
Sure. Now it's kind of, it shows up on certain areas with psoriasis, in particular elbows and knees. And that's probably due to trauma. Psoriasis will come out from any type of scratching or rubbing.
I
So
see.
the idea, you bump your elbows and you get psoriasis from the rubbing on your elbows, and maybe your knees rub on your pants, or you kneel down once in a while. So with psoriasis, it's primarily elbows, knees, but it can come anywhere. And it can get into your nails too.
There are
Your
pretty good
nails can-
treatments for it these days, I guess.
Psoriasis is fairly treatable. There's many treatments for psoriasis. What that means is there's no cure for psoriasis. There's many treatments. If it's not too bad, you treat it with creams, like a cortisone type cream. Will slow down the growth of the skin. There's other types of cream. There's vitamin D cream called a Dovanex, and that helps to normalize the skin. There's vitamin A derived creams. Tazarac is one of those.
So the
It's kind of
vitamins-
related to retin A, but that'll help normalize, kind of bring it back down to that growth cycle of, a month or 2. And then if that's not working, you can do systemic treatments. You can take like a vitamin A type pill called Soriatane. You can take methotrexate pills to slow down.
Well, I use that in my patients because they
psoriasis.
get arthritis also with their psoriasis.
Exactly.
It works pretty well.
And so, psoriasis is, in essence, it's an immune system abnormality in which there's growth factors that are kicked out that cause the skin to grow too fast. So many of the treatments, they're similar to, rheumatology, anti-inflammatory treatments that are immunosuppressive. And so many of the same treatments that are used for like rheumatoid arthritis, they work for psoriasis. In fact, the new biologic injectables like Humira and Enbrel those also will help to slow down the immune system and normalize the psoriasis skin.
For the severe cases, some of my patients say it's like their miracle drug.
Yeah, absolutely.
Well, how about dandruff? Let's talk about that. That's a fairly common problem.
That's a glamorous problem. And basically, what you have is kind of a waxy scale. Usually it's on the scalp. You see flaking, but seborrheic dermatitis or dandruff often comes in the eyebrows. You can get that kind of waxy scale in the eyebrows, the central face, around the nose. It can also come in the chest and neck and the ears. It can be very bothersome and actually quite difficult to treat sometimes. And so the simple treatments have to do just with, washing, and that's like Head and Shoulders shampoo, just to kind of wash it and clear it out. It probably has some chemical benefit to help it. Now, the seborrheic dermatitis or dandruff, often these patients will have a normal type of yeast called Pityrosporum that lives on everybody, but it's overgrowing, and so there's a debate whether it causes it or not. But Nizoral is an antifungal, anti-yeast. There's a shampoo and cream form that will also help dandruff or seborrheic dermatitis.
Well, I'm glad there's something that can take care of it. It's more a nuisance thing than it is a big danger, I suppose.
Keep it managed.
Well, we don't have much time left, but why don't we talk a little bit about shingles, which is a nasty little thing. Tell us how you recognize it and how you treat it.
Sure. Whenever anybody comes in and they have blisters and a red rash coming around the right or the left side of their back or their face and kind of a stripe, that's what shingles is. And it's the chickenpox virus coming back on a nerve root.
Harking back to
and
childhood.
So, right, when you're a kid, you get chickenpox, goes away, and then the chickenpox virus kind of hibernates on your nerve root. And then probably about 20% of the time, at least 1 out of 5 people will eventually get shingles, which is a very large number, actually.
Now, how about if you had chickenpox vaccination as a kid and never got chickenpox?
I've seen people that actually have had chickenpox vaccination and they've gotten shingles at a young age. I'm not sure when the chickenpox vaccination was started, but it's not 100%. And basically, the chickenpox virus, it returns on a nerve root, and it causes lots of damage in the nerve. And as it gets to the skin, it causes blisters in the distribution of the nerve.
One of the most painful things you can get, I think.
And very painful, and if it's treated early, though, it can be basically cleared up without a lot of problems. But it can leave pain for years or a lifetime if it's not treated at all. So it's important to recognize it early and treat it early.
Does stress have anything to do with shingles, bringing it on?
Yeah, often shingles will come right after some sort of stress, whether it's an emotional stress or if you're, have an undiagnosed lymphoma or something, you'll come up with shingles, and then as you're being checked over, they'll find out you have lymphoma.
Well, we don't want to cause any more stress for our viewers today, so we're going to have to wind down the program. But thank you for watching Healthy, Wealthy, and Wise. We trust that it's been a help to you. We would suggest that you tune in to our website, llbn.tv, and we'll see you again on Healthy, Wealthy, and Wise.